Now we will jump to the last presentations, and after which Dr. Ahmed Shawqi will conclude the session. Professor Sayed Farag will speak about GLP1 agonist and cardiovascular outcome improvement. Dr. Sayed.
Thank you, Mr. President. Thank you, Professor Ahmed, for this really well-organized and very important session. And I'd like to take the chance to welcome you all in the 24th anniversary of the Cardioresc and Lipid Day. And I'm sure that you will enjoy in the coming couple of days a lot of the international and national experts who will present all the updates and most of the topics in lipidology, atherosclerosis, and vascular biology. Actually, we are so lucky that we are live in this era with all those innovations in the clinical challenges, especially diabetes, heart failure, and one of those innovations is the GLP1 receptor agonists. And to confirm that, we have a lot of evidences which support that this molecule is really an innovation, and I will show you those evidences in my coming slides. Before to dive to those slides, I have to remind ourselves that diabetes is considered as a cardiovascular disease equivalent, and this is stated since about 23 or 24 years by the American Heart Association. And by considering this statement, I think it will push us to take all the opportunities we have and all the weapons we have to counteract this major problem, which is considered as a cardiovascular disease equivalent. Another important bleak fact that 2 out of 3 people with diabetes die from cardiovascular disease. And that's why I think Professor Ahmed Shawqi chose this topic for cardiovascular outcome improvement by using the new drugs and the new innovations which came up to the stage. There is one question during the start of this session about the what's called the pleiotropic or the beyond the glucose metabolism for GLP-1 receptor agonists. For example, in the liver, it decreases the glycogen storage, and for the GI tract, it decreases the motility, and for the brain, it is also act as neurogenesis. For the kidney, increases the natriuresis. For blood vessels, increase the endothelium-dependent vasodilatation, and of course, over the heart, the myocardial contractility, the heart rate, the ischemia-induced myocardial damage, and also on the pancreas, which upregulating the insulin by senses, and on the skeletal muscles with increasing the glucose uptake. Also, it is worthy to mention here the potential mode of action for the GLP-1 to impact the cardiovascular disease by decreasing the inflammation, increasing the glucose uptake, decreasing the ischemic injury, increasing the LV function, as I mentioned, and increase the heart rate, not only on the myocardium, but also in the vascular wall by decreasing also the inflammation and increasing the endothelial function, doing vasodilatation, doing plaque stability, increasing the blood flow, and decreasing the platelet aggregation. We can see a cluster of issues that can be tackled with the GLP-1 impact on cardiovascular disease. This is an important slide to mention about what are the major adverse cardiovascular events. We have what's called the 3 points MACE, which is the cardiovascular death, non-fatal myocardial infarction, non-fatal stroke. And it is worthy to mention why, because all the evidence that I will mention in my slides were based upon MACE, and the 4th point MACE here is the additional components, what's called the MACE plus events like hospitalization for acute coronary syndrome, urgent revascularization, or heart failure. In 2016, the most evident trial came up to the stage, which is the leader in 32 countries, recruiting about 11,000 people. And I think also here there is about 2,600,000 data points entry, which a lot of data entered in this landmark trial. And the patient randomized to placebo and liraglutide, which is the GLP receptor agonist, of a dose of 0.6, 1.8 for a duration of 3.5 to 5 years. And the primary outcome, as I mentioned, the 3-point MACE, which is a cardiovascular death, non-fatal MI, non-fatal stroke, and the key secondary outcome here with the extended composite cardiovascular outcome, all-cause deaths, and each individual component of expanded composite cardiovascular outcome. If we have a look here to the results, compared to the placebo, the primary composite outcome, the cardiovascular deaths, the non-fatal myocardial infarction and fatal stroke, significantly reduced by relative risk reduction by 13%. And also here we can appreciate the individual component of the primary endpoint, which favors the liraglutide over the placebo. Also the cardiovascular deaths, here relative risk reduction of 22%. The non-fatal myocardial infarction by 12%, the non-fatal stroke by 11%, and the all-cause deaths by 15%, and finally the hospitalization for heart failure by 13%. If we are talking about efficacy, we have to talk about safety also. It is as shown here, it is safe compared to the placebo as regard any serious or severe adverse effects. Number needed to treat to prevent one MACE is 66, all-cause death is 98 for 3 years, which is also considerable. And as a summary for this landmark trial, liraglutide, in addition to the standard of care, reduced cardiovascular risk in adults with type 2 diabetes of age more than 50 years with established cardiovascular disease, or age more than 60 years with one or more cardiovascular risk factors, 13% reduction of cardiovascular deaths, 22% of cardiovascular deaths, 15% deaths from any cause, and 22% also for the renal composite outcome, like a decrease in eGFR by 40%, dialysis, or renal death. And as worthy here to mention that by protecting the kidney, we are indirectly protecting the heart. And then a lot of studies came up to the stage, like the SUSTAIN trial testing the semaglutide 1 milligram. And here the conclusion was the injectable once a week semaglutide was superior to placebo in improving glycemic control, but not only, and also decreasing the cardiovascular events in high-risk patients with diabetes. Then also in the Lancet about the albiglutide, also in patients with type 2 diabetes and cardiovascular disease, albiglutide was superior to placebo with respect to the major adverse cardiovascular events. So we are seeing a lot of data and a lot of evidence came up to the stage. And in 2019, the REWIND trial also, which is testing a global and double-blind cardiovascular randomized control trial, we can appreciate here that the dulaglutide significantly reduced the risk of major adverse cardiovascular events by 12% versus the placebo. And there's a consistent effect across 3 components of MACE, and the greatest difference observed in the non-fatal stroke in this trial. Then, few months ago, at the end of the 2021, the Amplitude trial, which is testing the ifepiglutide cardiovascular outcome as one of the GLP receptor agonists. And here, the epagliflozin is an exentin 4-based GLP-1 receptor agonist. It is prolonged half-life by conjugated with immunoglobulin G4 Fc fragment with a dose range from 4 to 6 milligram given subcutaneously. Similar clinical effects in phase 2 and trial, lower the glucose without hypoglycemia, and the effects on cardiovascular and kidney outcome at the Amplitude was unknown. So that's why the came Amplitude outcome trial. The Amplitude outcome trial assessed the cardiovascular and the kidney effects of ifepiglutide in people with type 2 diabetes. With a high prevalence of cardiovascular disease, with a high prevalence of renal disease, with a high hemoglobin A1C, with a moderate use of an SGLT2 inhibitor. This is a cluster of risks for those patients, and also with a moderate use of an SGLT2 inhibitor. Recruiting more than 4,000 people in 28 countries and 5 continents. And here the outcome we can appreciate here the significance of superiority for 0.007 compared to the placebo. And also the expanded MACE composite outcome event was significantly in favor of the GLP ifbiglantide, and also the renal composite outcome event, also it is significantly reduced compared to the placebo. The overall conclusion here in the Amplitude O trial showed that the GLP-1 drug ifbiglantide safely reduces major cardiovascular and renal outcome in high-risk people with type 2 diabetes while lowering glucose and blood pressure and also weight. Because of these clusters of trials, few weeks ago, the Cardiovascular Diabetology Journal came up with a very important review about the cardiovascular outcome trials, a paradigm shift in the current management of type 2 diabetes. A long journey started since 2016 by the leaders, Sustain, then the Harmony, also the Rewind, and finally the Amplitude, which is assessing the 4-point MACE. And this is, of course, reflected on most of the guidelines, either in the cardiovascular or in the diabetes. For patients with type 2 diabetes who have established atherosclerotic cardiovascular disease or high, very high cardiovascular risk, SGLT2 inhibitors or GLP-1 receptor agonists with proven cardiovascular benefits are recommended as a part of glycemic management. This was in the EDA just this year, 2022. The American College of Cardiology recommending the same recommendations in 2020, and also the European Society of Cardiology do the same recommendation for those patients with diabetes and cardiovascular disease for better outcome. And thank you for your attention.
You know, a great lecture, a great overview on GLP-1 receptor agonists and how they are changing in the future. They're becoming oral, they're becoming once per week, they're becoming reduction of myocardial infarction and strokes. These, with the medications of the SGLT2s, I think there is a huge benefit for our patients. For the sake of time, is anybody having a question? Anybody question? Professor Sayed, Professor Temer have given us a great presentation. Thank you, Professor Sayed. Thank you so much.